It's a real pleasure to be here for this first plenary of PMAC 2020 on accelerating progress towards UHC. As you may have disappointingly noticed, I'm not Dr. Fiona Godley, Editor-in-Chief of the BMJ. Some of you may know that Fiona was unwell yesterday, but I'm pleased to report that she's been discharged from hospital and sends her praise and thanks to the Thai healthcare system. She apologises for not being here and is very sad not to be part of this plenary. So my name is Dr. Ashley McKimm. I'm Director of Innovation and Improvement at the British Medical Journal and past Chairman of the UK Medical Journalists Association. My role this morning is to facilitate this opening conversation, which I hope will set the agenda for the next 3 days of PMAC. Health is a fundamental human right, which should be enjoyed by all people. Yet nearly half the world's population still is unable to access even the most basic healthcare services. We're joined in this session by some of the main organizations, exemplar countries, and civil society representatives to discuss some of the key challenges to UHC and how we can overcome them. I'll be asking our panel some difficult questions, but we also want you to contribute to the discussion too. So please share your thoughts, experiences, and questions via Twitter using the hashtag PMAC2020, and we'll also take some questions from the floor towards the end. So please put your hands together for our distinguished panelists. Back in 2015, when UHC was included in the Sustainable Development Goals, it offered a beacon of hope for a healthier world. But progress, to put it mildly, has been slow. Our challenge this morning is to see how we can accelerate that, how we can bring UHC to the billions who struggle to receive even the most basic healthcare. Before we start the discussion, I'd like to ask the panel to introduce themselves to the audience.
For myself, okay. I'm Naoko Yamamoto, Assistant Director General and in WHO headquarters and in UHC Healthcare Population Division.
Good morning, everybody. My name is Daniel Dulitzky. I am Director of Human Development for East Asia Pacific at the World Bank.
Morning, everyone. My name is Evalin Karijo from Kenya. I'm the Director of YACT, Youth in Action at AMREF Health Africa. I'm also on the advisory group of the Civil Society Engagement Mechanism for UHC 2030.
Good morning. My name is Anders Nordstrom. I'm the Swedish Ambassador for Global Health, based in the Foreign Ministry in Stockholm.
And good morning. My name is Ariel Pablos-Mendez. I am a professor of medicine at Columbia University in New York.
Good morning. My name is Oanh Khuat. I am from Vietnam. I'm the director of the Center for Supporting Community Development Initiative in Vietnam, and also the steering committee member of UHC 2030, represents civil society from developing countries.
Thank you. So as you've heard, we've got a huge amount of experience on the panel today, and I want to thank our panelists because many stepped in at the very last minute, so thank you for being here. I want to kick off this session by asking each of you for your reflections. So looking over the last 5 years of the SDGs, your thoughts, your thinking, your understanding, and maybe starting with you, Dr. Naoko.
Thank you, Ashley. And let me say that the 3 big lessons and learn we did during the past 5 years. I should say first is UHC is highly political. We heard and also the first session and the previous session speaker said that DG said WHO Director General said that UHC is a political choice. Yes, it's true. It's a big political choice, and many high-level political leaders committed and achieved a lot, and even in a very small period. But also we have to think about the UHC is a social system and a social contract. So the engagement with the people and the effective dialogue system, especially institutionalized dialogue system, is very important. This is one lesson we learned. Second issue, if I can say that, even though the way to achieve UHC are different in countries, we have 2 common keys, I think. One is domestic financing, domestic public financing. And international aid is right now the less than 1% in the health sector. So, and now because of the economic growth, or country is getting richer and poverty is declining, and income growth is come to the coverage, increase the coverage of health services. However, it's not necessary to avoid financial hardship and inequities. And another two common issues is the importance of the health workforce. Not only the health professionals, but also government officer, manager, in local government and central government, and the community leaders. Finally, I should say that measurement and monitoring, and using the local and national global data, share together, use the data as a policy. That's the three lessons I think learned.
Wonderful, so thank you. And I think we'll come back to some of those challenges, particularly around the financing, as we move through this discussion. I want to move on to Daniel at World Bank, and I think you've played a key role over the last 5 years in driving this momentum. What's your reflections in 5 years and where we've got to?
Thank you, Ashley. So let me start by saying that I think the best thing I'm going to say today is that every one of you should go back and read the opening remarks by Her Royal Highness Princess Dina Mired and by Mr. Ban Ki-moon. Memorize those words and take them with you everywhere you go. So I think that's probably the best thing I'm going to say today, but since I have 3.5 minutes left and I'm not going to give those minutes away, I want to say a few more things. One is that I am an economist by training, and so I approach the topic of universal health coverage from an economic standpoint. And I think one of the challenges that we have had over the last 5 years is that we always say that time is money, but we haven't been able to say, we haven't said enough that health is money too. Good health is money, and poor health is money, as we are seeing now with the recent events with the coronavirus outbreak. And so at the World Bank, what we have done is to develop a human capital index that was launched about 1.5 years ago that measures the future productivity of a person born today in a given country, given the health and education outcomes in that country. And we have shown with a very simple measure that health and education have a very strong impact on productivity and growth. The country with the lowest human capital index is 29, and that means that a person born in that country today will have the productivity of that person will be 29% of the potential that this person could achieve if he or she had perfect health and education. And that's a huge cost. It's a huge economic loss. And I think we need to internalize this message and distribute this message more widely. Other challenges, I think there is also a challenge in terms of the level of funding. And this is a humbling number. A recent report prepared by the World Bank estimates that in the poorest 54 countries, the financing gap for UHC is going to be about $175 billion in 2030. It's really a very large number, and any development assistance for health is a drop in the bucket here. And therefore, the next challenge is how to increase domestic resource mobilization in those countries, right? Again, looking at the economics of it, developing countries have a lower revenue as percentage of GDP than higher income countries. And the next challenge related to this is also the prioritization that health takes on the government budgets. We heard the Minister of Health of Thailand say that 17% of the total government budget in Thailand is devoted to health. That's a very large number, and it's unusual, and Thailand should be given credit for that. But in many other countries, in most lower income countries and middle income countries, that number is maybe at best 10% on average. And the last point, I think, the other challenge that we face is how we use the funds, how countries use the funds. And I think there is a lot of, we need to recognize that there is a lot of waste in the health sector. Our OECD colleagues estimated that about 20% of health spending is wasteful. And this is in OECD countries, but our guess is that the number is as large or even larger in developing countries. Finally, what I would say is the last challenge is how to make sure that countries focus the delivery of services in the most cost-effective areas, in particular primary health care. Primary health care should be given priority, and it should be obviously universal, but it should tackle not only communicable diseases, it should tackle also infectious diseases and health security issues, maternal child health issues, malnutrition issues, and obviously non-communicable diseases. Thank you.
Thank you, Daniel. So I think up to now we've been really talking about those macro level problems and challenges with UHC. One of the groups that's going to be most affected by UHC is the younger generation. So, PMAC's been fantastic this year. We've seen the growth of more students and young people involved in PMAC each year. But Evalin, your reflections in the last 5 years and thinking about the youth and the younger generation, where would you like to see this going?
Thank you. First of all, do we have young people in this audience? Where are the youth? Youth Viva! I can see a few hands, which is really good. Many hands, actually. This is good. I mean, when we talk about young people, we're looking at 1.2 billion young people around the globe. That's about 16% of the global population. And in some continents like Africa, over 70% of the population is below the age of 35. So the potential of this growing population to drive economies is at its greatest right now. And reflecting on the SDGs, while most of the targets make reference to the youth, unfortunately, we've not seen enough investments and resources that match these commitments for the young people in the SDGs. Sadly, young people continue to be affected by social inequalities, economic barriers. Young people are 3 times more likely to be unemployed than adults, and this contributes to the financial barriers of accessing and affording health care. When you look at fragile states and conflict-stricken areas, young people bear the brunt. Young people who are in these marginalized regions have poor health outcomes, but also most times have to choose between putting food on the table and accessing health care. And yet, these are both basic human rights, and they don't have to choose one or the other. So right now, we need to look at investments for young people, investments that focus on primary health care, and I want to agree with my colleague. We need to invest in primary health care and health promotion, which mainly benefits young people. Right now, we are spending so much on combating non-communicable diseases, and yet, if only we would invest in adolescents and youth, most of these conditions can be averted within the adolescents and the youth phase of life, and even childhood. So we just need to refocus our investments and tackle these challenges by investing more in the priorities and the needs of the youth and adolescents. Thank you.
Thank you. So let's move on to a country that's achieved UHC, that's mature. Anders, tell us a bit about Sweden and where you see the challenges, not just that you've managed to get through, but challenges for other countries as well.
Thank you very much. I would like to look back both 3 weeks and 70 years. 3 weeks ago, I had a back surgery, and 8 o'clock in the morning, I came to the hospital. 3 o'clock, I went home. 8 o'clock Monday morning, I was back at work. Fantastic for me because I had a pain for 4 months, not allowing me to walk. But more fantastic was that I paid $20 US. $20 US for the surgery, including the transport back home. I tweeted this, and I got 67,000 people reading this, 4,000 people interacting with that tweet. The first one actually came from Kenya. People across the world saying, how can we get UHC as well? So how did we do it in Sweden? Then I need to look back 70 years. This was after the Second World War, and we were lucky not to have been part of that. But we also were lucky to have a Minister of Finance at that time, and also a leader from the private sector, Marcus Wallenberg, who actually made a very unconventional deal, saying that we need both social development and economic development. So from the business side, they recognized that they need a healthy population. Most importantly, they needed women out in the labor market, But the only way of doing that was also to invest in social security. So then we decided to have a system of universal health coverage. We decided to have childcare. We decided to have a pension system. And all of that allowed mainly then women then to enter to the labor market. What has been the impact of that looking back now? Huge improvements in terms of health. Both life expectancy, we have one of the lowest child mortalities in the world rates. But also if you look at NCDs, strokes, coronary heart infections, the mortality rates have gone down considerably. And of course, more importantly perhaps even if you're a doctor, is that this has contributed to economic development and to gender equality in Sweden. Today, we have, in addition to the priorities for economic development and social development, a very strong priority also for the climate and the environmental dimensions of development. Yet, I mean, the system is not perfect. Today, we still have big gaps in between the health outcomes, in between different socioeconomic groups. But my reflection, or the fact is actually that this has no longer to do with access to universal health coverage. Everybody have that opportunity in Sweden. Good quality, I was not an exception. I pay a lot of tax, but still everybody have equal access to good quality health service in Sweden. But the gaps in terms of health outcomes in Sweden today has to do much more with the underlying factors. Your exposures to risks, the underlying determinants of health. So this is a different agenda that we are working on now in Sweden today. Thank you.
Thank you. And we'll come back to some of those challenges, I think, as we go into the next question. So, Dr. Ariel, you've been involved, I think, through the last 5 years in trying to shape this agenda. Maybe give some of your reflections on where we've got to.
Well, thank you. And let me go back a few more years. I think when the first PMAC was organized in 2007, the theme was improving access to essential technologies. And that was the mantra at the time because that was a great need in the global health space. And this community at the time was not talking USC. So I mentioned that just to show the incredible progress of an idea, a powerful idea, the time of which has come with the changes in the political economy. And this is a global agenda issue because things, of course, were not new. USC over a century, from Germany to the UK to Canada to Japan, the Alma-Ata Conference on Primary Care. But also more recently, the countries were happening already here, Thailand, Ghana, Mexico, Rwanda. And that proved that this was something that was feasible at the country level. But at the global level, it was not at all on the agenda. And in that same year, 2007, I was lucky at the Rockefeller Foundation organizing a meeting at Harvard on the agenda on priorities for health systems, which was a hard area to sell. And I was lucky to meet there at Harvard Professor Keiso Takemi, who lucky, I guess for me, he had lost the election in Japan, and so he was taking a sabbatical. But Japan was to host the G8 the following year in 2008. Japan had been so instrumental with the previous G8 to bring the Global Forum and the birth of the Global Fund. This time, the G8 in Japan and Hokkaido, they embraced the health systems agenda that Keiso brought with papers. So academia was very important, knowledge was very important, as we hear from our Thailand friends, the triangle that moved the mountains. You need the ideas, the evidence, then you need the support of the social movement, as it was called here by Suit in Thailand, to get this going. After that, of course, we got energized by the fact at the time, I published a paper in The Lancet in 2008, calling all for USC, and produced the first map of USC with ILO data that we should not have data or the World Bank at the time. But maps were important for global health. But more importantly also, we had the engagement of the World Health Organization with the World Health Report in 2010. The World Bank, that in previous eras had been at odds with WHO, they began to work together, and that's also very, very, very important. The Lancet Commission on Investing in Health made the case that this was rational from an economics point of view. Very important also was the Working Group on Foreign Affairs and the engagement by champions here in Thailand, in Norway, in Kenya, in Brazil, in France, to engage the foreign affairs and bring to the UN 2012 the first resolution inviting the countries to consider this. And then the SDG, and Anders and I were at the time representing our countries in the deliberations for the SDGs. And it was amazing that the idea of USC, and I was a champion, but I was surprised that others were trying to put USC as the one overarching goal. So the idea had legs, and it kept growing over time. Then the Prime Minister of Japan personally put a leadership signature on this issue with the 2017 Forum of USC, and then, of course, last September, UNGA. So we have come a long way. I think that it is the idea, the hunger for justice, the moment in the political economy. I think we have come a long way. But of course, this is a country where it needs to happen. But we always knew that it's not only about the Minister of Health, it's about the heads of states. And so the political commitment through the UN becomes very important, the SDGs becomes very important, and now the follow-up and the accountability with good measurement and follow-up is what I see as the most important processes for us going forward.
Thank you. So thank you for highlighting as well. I think earlier today we were talking about the sort of being quite critical of the progress made of UHC, but actually you very nicely kind of highlighted some of the key achievements as well over the last 5 years. So thank you for that. I want to move on to Dr. Oanh, who's a representative of civil society. So I think from your perspective, what do you think is important? What do you think the challenges are at this point in time after 5 years?
I have to disclose that USC has been my dream since medical school day. So it was back 30 years ago. So the last 5 years has been like emotional up and down for me and for many of my civil society colleagues. We were so happy that USC was included in the SDG 2030 agenda. We was like really cheering and jumping and so happy. And then we see that many countries are interested in health. So if you look at the voluntary national review of the SDG 2030, most of the country, 97% of the country review SDG number 3 is about health. And about more than 3/4 of the country review USC. But the interest doesn't really translate it into concrete policy and program and services. Only 20% review some sort of USC performance, and only 5% review the service coverage indicator, which is UN SDG indicator. So that speaks to the fact that the interest is there, but even political will was not there, reflecting in the review report. If they do seriously care about USC, it must have appeared in the review report of the country. And that also explains the fact that now we are in 2020, we are in starting the second decade of the second millennium. We are only 10 years to 2030, and half of the world population don't have access to essential services. And our pocket payment, financial hardship because of healthcare has become more severe than ever before. So that is political, interest is there, it's in the agenda, but political will was not there. But in the darkness, we saw the light. We saw the leadership of some country, including Japan and Thailand, to make USC become an UN agenda. That we had the high-level meeting last year. It was a bright spot, and I know that a lot of work was put behind. We as civil society really appreciate the leadership of the country that really make USC into the global agenda. But now after that, we was worried again. So will political declaration, the political declaration on USC is a progressive one. It's not as good as we would hope for, but it's the best we can get, I think. And the best thing about it is reaffirm the rights of all human beings to health. It's also reaffirm a leave no one behind agenda, of reaching the furthest behind first. And for us, that's the best part of the political declaration. But we have the risk of political declaration become a beautiful decoration, a window dressing, if no concrete action to be taken. So I would take this PMAC the USC Forum 2020 as the next step to concretize the action. This should be the last global political momentum to put things in action. I would please to all of you that we don't have a big meeting again until the USC start to be realized in the country. So, thank you.
So thank you for that very strong call to action. So we've highlighted some of the key challenges in UHC. We've touched on the financial pressures, the role of the political agenda, the challenge set by young people. We've talked about an aging, mature population. We've touched a little bit on the academic progress, the building up of evidence of what works for UHC, and then we've talked about the dreams of UHC and what that can deliver. In the interest of time, I want to move us on to really focus on some of the ways we can solve those challenges. But before I do, I want to remind you that you've got a chance to submit some questions to our panel as well. So please do send your questions on Twitter. The hashtag is PMAC 2020. So let's move on to thinking about those challenges, but actually your advice, your thoughts, your experience on how we might be able to overcome some of those. And I want to start with Evalin, actually, because I think we are talking about the younger generation here. So it'd be good for you to feedback on your expectations. What do young people expect from our political leaders around UHC?
Thank you. I'm going to highlight 3 expectations for the global leaders and the policymakers. The first is the need for us to redefine meaningful youth engagements in not just the UHC processes, but in policy and decision making. And I think I want to start by commending the UHC 2030 team, because young people were not left behind during the multi-stakeholder consultations before the high-level meeting. We consulted youth from various movements, the International Federation of Medical Students Association. We consulted young people from the Youth for UHC movement in Africa. We got views of young people globally, and young people supported Ask Number 6 on moving together, because we acknowledge the benefits of partnerships. So when we talk about redefining meaningful youth engagements, it will be important for policymakers to have collaboration and partnership with young people. We do not want young people to be meaningfully engaged because of tokenism. We want to acknowledge that as youth, we are capable, we have the skills, we have the knowledge, we have the capabilities to contribute to policies. So young people need to be involved in these policy decision-making processes. And in Africa, we've been able to redefine this by having a partnership whereby policymakers and youth keep each other accountable. So we are not just asking policymakers to be transparent and inclusive and accountable, but we are also challenging ourselves as young people and saying we need to be accountable. We need to show up when we are called for policy meetings. We need to get acquainted with the policy processes and give meaningful contributions. So investments in meaningful youth engagement should be a priority. The second is on financial strengthening. As policymakers, we expect to see investments from you on various health benefits packages that respond to the needs of the youth. Right now, many adolescents and young people, for example, cannot access contraception without parental guidance. Where are the policies around this? Why do we have to have restrictions based on age? When we talk about financial limitations, we need to ensure that social security premiums take cognizance of the fact that young people have less financial and economic ability. So we need to ensure that premiums are actually beneficial to young people and that young people are able to afford health care. When it comes to collaboration, we want to see multi-stakeholder collaboration between different departments, not just the health ministries working alone, but we need to see collaboration between health ministries, education, and ministries on economic empowerment. That's the only way that young people can benefit. In countries such as South Korea, the reason why they've done very well is because they've implemented health promotion policies in schools. So young people can only benefit when policymakers and different ministries work together in collaboration. The third ask, and the last, is on innovation and technology. Right now, young people are the biggest users of technology and innovation. But how are we investing in youth-driven and youth-led innovations? How are we ensuring that young people's innovations are at the fore of achieving UHC and other policies. Most times we hold hackathons with young people and they come up with really good innovations, but then there's no one to invest in that. Who do we partner with? We need to see investments in innovations for the youth, in artificial intelligence that is led by the young people. And to end, I'm going to give an experience of an innovation in East Africa that has, revolutionized how young people are included and how they take part in the healthcare system. We have an innovation that is called Chukua Selfie, which means take a selfie. But it doesn't mean take a selfie literally. It means test yourself for HIV. So it's a self-care approach where young people are using technology to actually purchase a self-testing kit, and they can even talk to medical practitioners and get advice on where to get drugs through their mobile phones. So we need to invest in such innovations. We need to have youth-centric innovations and technology, and we hope this is something that the global leaders will take up for us to achieve UHC. Thank you.
Thank you. So Dr. Naoko, that's a real call to action for our healthcare leaders. What's your reflection? So how do we get our global healthcare leaders to respond to that?
Thanks. Well, I think it's going to be about politics, it's about financing, and it's going to be about the energy of social justice and making sure those three are aligned. The momentum on the SDGs and the UNGA needs to be accelerated at the level of the heads of states. Universal coverage is politically determined, and it's country-owned and is domestically resourced. And the engagement of the heads of states is really paramount. So keeping that engagement, the work that the elders are doing is really very important. We also need better understanding of the economics. Quite often, a roadblock to reform is we're spending too much, or we cannot afford it, or it's been growing. This is all a misunderstanding. And while USC requires a lot of understanding of the financing, is not about being concerned this is too much and so on. Universal coverage is not about spending more. It's about reorganizing domestic resources away from out-of-pocket expenditure. This can be done, has been done, needs to be done, and out-of-pocket should be less than 20% and shrinking, not growing. And pay attention to that in any country, and you will know where things are going. Total health expenditure is growing and will continue to grow in all economies as they develop. This is the first law of health economics, and you can expect it as opposed to worry about it. And that resource needs to be, again, organized. Tightening budgets, public budgets, all it doesn't control this fact, this law. It only opens private sector activity, which is something by default as opposed to a vision for a nation. And while concerning for budgeting process, the growth in total health expenditure is actually affordable. In the United States, where we are so concerned that 18% of the largest economy in the world being devoted to health, and yet the United States remains one of the most competitive nations in the world. So it certainly can be done without destroying your economics. And so dispelling misunderstanding of economics, doing the research, showing that to ourselves. Because oftentimes we believe something we wish, but we also sort of agree that we cannot afford. This is a mistake. We need to really address that mistake with evidence. I think Her Majesty the Princess earlier asked, who will foot the bill? And the answer is, of course, countries will. The question is not whether we pay for some or out of pocket or through USC. These really the choices countries will have to face. But for USC, the real energy has been the hunger for social justice that was behind the movement on the AIDS movement earlier, and now is the same energy behind USC. We need to keep that torch, that fire going at the grassroots and the high levels, and also with concrete examples. And I would like to put forward one suggestion to all of us. Global health in the golden era has delivered incredible results in terms of maternal child health, HIV, TB, malaria, life expectancy. It's amazing. Development has succeeded in so many ways, so that income in many countries have moved them from low to middle and middle income. It's been an incredible era the last 20 years. A woman now in Africa who will bleed after delivering a baby would have died before. Now she can go to a hospital. But today, even though those countries spend more, that woman is being kept in a private jail in the hospital until the families sell their motorcycles, their chickens to pay the bills. Clearly, this cannot be the future and success of the global health efforts of the last 20 years. We need to change that. Of course, the reforms will take time and effort, but something simple can be done today, and that is an invitation for all of us to call for the legal ban of private hospital jails around the world. And I invite Naoko and WHO also to follow through on that. Thank you.
So I think let's pick up on some of the financial points you mentioned and the role of public-private partnership there as well, and how we can use that financial investment and drivers for UHC. And maybe let's come to Daniel and just have a bit of reflection from World Bank and World Bank's take on how we can overcome some of those challenges we talked about earlier.
Thank you, Ashley. So let me maybe make 2 or 3 points addressing your specific question too. I want to emphasize something that was already said, and it's a bit of a cliche, but it's no less important because of that. I think political will and leadership is essential for a country to achieve universal health coverage. And so the leadership at the country level will also help promote universal health coverage at the global level. So, for example, when we look at the experience of Thailand and how it reached UHC in 2001, before becoming an upper middle income country, we can take that experience and showcase it and use it as an example for other countries and inspiration for other countries. We also need leadership at the global level, and I think I want to recognize here the government of Japan, because they have continuously made the case of the importance of universal health coverage as an item of interest for the global health community. I also think that, it's related to the role of the private sector, but I think it's a little broader. I think we need a whole of government approach. In my view, and again, I'm speaking as an economist, in my view, I think that the languages that are, the language spoken by ministries of health is different from the language spoken by ministries of finance. And sometimes this makes it impossible to communicate properly about the importance of universal health coverage. So anything we can do to help both ministries converge to a common language, I think will add tremendous value to the possibility of achieving universal health coverage. And again, here I want to recognize Japan, because when Japan had the presidency of the G20 in 2019, they organized for the first time a dialogue, a meeting between ministers of health and ministers of finance to discuss universal health coverage. One issue related to this is, for example, health taxes that was raised by Her Royal Highness today. That discussion cannot be done in isolation. It cannot be driven only by a Ministry of Finance or by a Ministry of Health. It has to be driven by both. In terms of the role of the private sector, we obviously, the private sector is everywhere, right? And so I think we just need to make sure that there is a strong public sector that will exercise a strong regulatory capacity and define the boundaries of the intervention of the private sector. Sometimes the objectives of a private sector might be different from the objectives of the public sector, and therefore a strong public sector is necessary to monitor and to enforce. But obviously, there is a role for the private sector in the provision of services, for example. We cannot ignore that. Thank you.
Thank you. So I want to keep us moving in the interest of time. Let's come to WHO. So let's have a bit of reflection on the back of that from your thoughts around the role for WHO going forward.
Yes. Yes, I listen carefully, and so many keywords has already arrived. But the service coverage financing issues we have already discussed, but let me say 3 issues. One is I really would push health promotion and prevention now in the context of the UHC. Of course, the people will be sick and go to the hospital and have access to the quality health services or care without hardship or financial hardship. It's great. But before to do that, we need to think about push prevention, health promotion. But at the same time, I should say, many outside health issues, like a big transition in the world, climate change or demographic change, and aging issues, many issues has a negative, or sometimes positive, but some big impact to the health. So how address the issues in the health? And another session that I said that, but at the same time, how health people can shape or influence the big megatrend, transition issues to change the world anyway, happier and healthier and safer. This is our big vision. That's what I want to say. Second issue is, again, if you talk about the primary health care, of course, national policy, big top of the leaders, political commitment is important, but it's done by local government, done by community level. So how we could strengthen the capacity, engagement with the community people, and how bring that good experiences and lessons learned, we learn each other. So WHO would like to create a platform, but also come up with good evidence and data to share with all of us. Third, finally, it's I would like to say, again, would like to emphasize how we can reach the people, unreached people, and how we can provide services and care and support to the people who need the most. This is a big challenge that we always need to think about the issues together with all partners. That's why I would like to highlight.
Thank you. So we've been talking about the care for the most. Anders, coming to Sweden, you've got a different challenge with UHC, and you've got an aging population as well. Some reflections on what's come up in the discussion so far.
Thank you. This is a bit unusual for me to speak about Sweden. I normally speak about global health, but it's interesting, I think, also to reflect on your own country and what one can learn from that. Listening to Ariel about the US, I think there is things one can learn from Sweden in terms of how much we spend and what is actually the outcome in terms of healthcare. Same thing, of course, for Thailand. As I said initially, I would like to say just one word before that, before speaking and talking about UHC and the aging population and the challenges and what we do. Just that what I said initially was that in some way we have achieved, quote unquote, UHC in Sweden, but that is not enough. So what we are faced with today is that we need to go beyond UHC in order to be able to close the gaps in between the health outcomes for different socioeconomic groups in Sweden. And that takes us in some way to what I call the WHO's third pillar. I think the WHO present general program of work is very useful. Talking about the importance of UHC, talking about the importance of what we see now with the coronavirus, managing outbreaks and emergencies, but also saying that we need to deal with the society at large, making sure that people actually can stay healthy, that we can prevent, and that's really where we are today. And in more simple word, we need to ensure that we get societies that are safe. We have safe roads. We have a big conference in Sweden now in a couple of weeks about road safety, but also from violence. We need to ensure that societies are clean, cleaner air. We need also to ensure that societies are supportive to people to make more healthy choices when it comes to food, alcohol, and smoking. And this is really those issues that will have most impact today beyond UHC in Sweden. So I'm actually very happy, and I was part of this defining now the present Sustainable Development Goals, that the SDG, I'm apologizing for saying that in a UHC meeting, that the SDG 3 is not UHC. UHC is a very important means to achieve more healthy populations, to ensure that people can live long and healthy lives, which is now the SDG 3. There were some discussions about that at that time. If I go to Sweden then, and as you said, we have challenges. We have an aging population, which we are very happy for. We have some other challenges to our UHC system, is that more and more people are also now beginning to take a private health insurance, saying that the public system is not good enough. We have still a challenge in terms of not having enough people using primary health care, still using hospital care. We still have a challenge in terms of having very many health workers per capita compared to other countries. So we do have challenges also to maintain the very good UHC that we have in place. So sharing what are we doing about this? Some practicalities. First, really to go back to the important act we have for health in Sweden, which really recognize UHC in some way, the principle for UHC as the main content. Everybody's equal right to good quality of health service regardless of ability to pay. That's the focus, people's equal right. And really to go back to those values, including now when more people are getting private health insurances, there is no way that you can just pay and then you will have easier access than other people. That's a basic value in the society. So we keep that, the progressive way of financing, and again, in the meeting in New York, I was extremely happy with Dr. Brundtland when she spoke about the progressive financing. I think that's a key in order for us to be able to maintain, to finance the system. Something else we're doing in terms of also to maintain the financing, to be able to manage the aging population, is that we're increasing the pension age in Sweden. So now pension age will be 67 years. I remember a previous prime minister, he suggested 75. And then people became a bit concerned. And actually the main concern was not that you had to work for longer, more years, but it was, will I be able to be healthy? If I will be happy to work for more years. But the kind of structure we have today, that you are education longer, you're entering the labor market later, you're having children later, all of that sort of moves in the direction, then we need to work a few more years longer. So if I compare my neighboring countries in Europe, I think at least I'm happy with the decision by the government. And I will also have the possibility, I'm now turning 60, I will have to work to 67, but I can actually work to 69 if I like, and I think I will do that. Because this is important, not just for you, it's important for your health, but it's also important for the economy of the country. The two other things we're doing as well, that is also really to focus on quality. So what we have in the Swedish system is what we also call quality registers, built by the professions themselves, focusing a lot in terms of what is really the outcome of different kinds of health services. Open comparison in between different parts of the health systems, really to continuously push for better value for money, better quality. And the final one, then coming back to the importance of what is beyond the UHC and the health system, is that we had a new public health bill now last year, emphasizing then, among other things, the importance of physical activity, urban planning, better food, etc. And I think the combination of that, I think hopefully we will have an even more healthy population in Sweden in the future. Thank you.
Thank you. So Dr. Oanh, I think the last word has been left to you as part of this part of the session. From civil society, what's your reflections and how do we kind of overcome some of these barriers?
Yeah, I think we are in a, okay, so we have enough political commitment or in terms of wording, in terms of document, to move forward. So issue is that we need to move. So the first pledge that I would like to make is to really fulfill that commitment of leave no one behind, reaching the people furthest behind first. If you go back to the definition of UHC, the UHC means that all people have access to health services that they need, when and where they need, without financial hardship. So that is the UHC. And we need to make sure that all people have access to the health services that they need. So usually when we look at the report on UHC, if there's a report, if the country put the number, we will need to look behind the number. We also need to look the non-number. So if a country say that their health service coverage is 80%, we will need the population coverage is 80%, we will have to ask ourselves the question, who are in the 20%? If the population coverage is 95%, we will need to ask ourselves who are among the 5%. And more importantly, who are not counted, who are not in the number. The people who are not counted in the number are the people who are left furthest behind. And we need to look for them. And we need to put them in the paper, in the policy, in the program. We need to understand why they are left behind and address their needs. What are their needs and address them. So I think that is our first call, first pledge. That is one of the priority of civil society on USC. Leave no one behind, reach the furthest behind first. But that means we need to know who they are and how to reach them and do that. The second goal is to invest better. So we already talked quite a bit about investment in USC. People mentioned PSC, and we totally agree with that. We are spending more money for health now. The total amount of the whole world spending for health is increasing, but it doesn't mean that we have more health, because we don't invest in the services that meet the needs of the most people. We invest in fancy hospital with fancy technology. So we need to go back to PHC, to primary health care. But beyond health, beyond medical services, because health is not only about medical services, as Dr. Yamamoto already mentioned. Health services, when we talk about it, including promotion, prevention, rehabilitation, and palliative care as well. So we need to look beyond that, and beyond the Ministry of Health, and not only Ministry of Health and Ministry of Finance. It's the whole society approach. It is a part of the political declaration. And my last point is, everybody already mentioned, USC is about political will. But we all know that politicians come and go. The priority of politicians change. The government change. So who will safeguard the USC agenda? It is civil society. But civil society nowadays have not got the attention, the space, and the investment needed to really participate and safeguard the agenda. We are privileged enough for the PMAC and for USC 2030 to create space for civil society, for young people to participate, but that space is not available in every country. And the investment for civil society, for advocacy, to participate in USC is not there yet. We need that. Thank you.
Thank you. So in the interest of time, we haven't got much time left, but I'd like to take some questions from the floor and also social media. So if you'd like to ask a question, please raise your hand or come to one of the microphones in the aisle. Please state your name, your organization, and please restrain yourself to one question if possible as well. And we're looking for questions, not comments here. So let's take one of our younger members first. Well, let's take one of our students. And if you can let us know who you're addressing your question to as well, that would be fantastic.
Many thanks for this opportunity. I'm a Japanese medical student trying to the access to the healthcare in rural area of Zambia and one of African countries. As Dr. Wan said, it's very important to take action, not just decorating the agenda. And in order to take action, it's very important to apply the local context into agenda. So here, regarding the real actions based on the political declaration of USC, I'd like to ask a question. That is, how to consider people's value when accelerating the universal health coverage? The people's value here, I mean, is such as the public trust into government or even the definition of public good. This might be influenced by the cultural or historical or psychosocial background which differ in each country. For example, like in Zambia, some tribes has a practice to get married to more than one wives, which cannot be applied to other developed countries. So the goal of UHC is not to complete the system or to increase the coverage rate, but to make sure that people feel secured, safe, and satisfied to the system. That's why I believe to consider people's value is very important to achieve UHC and also to secure the healthcare services and to satisfy the people. So let me highlight a question, that is how to take these people's value into consideration for developing actions toward UHC. Thank you very much.
Any of our panelists like to take that? And I think we'll try and keep the answers as quick and short as possible. And
just a quick reflection on that. Values, cultures varies from country to country. One way to think about this is actually what does it lead to in terms of health? Does it lead actually to improving people's health? A lot of what I was referring to also in terms of what is happening in society has to do with values and behaviors. So I think what is important always to think, I mean, all countries are different, but whether those practices, those values actually leads to improved health. So I'm very happy with the overarching now ways of measuring outcomes from WHO, which is healthy life expectancy, to see whether people really remain healthy. So that might be one thing, one way of thinking around values and cultures.
I'm going to move on. I want to make sure we take some questions. So we'll take a question from the lady with the microphone in the middle and the lady in the far side, who was at the back, I think has moved to the front. But before that, we'll do one off social media first of all. So a question for Evalin. You described the features of youth-centered PHC. Can PHC systems incrementally change to meet these needs, or is transformation needed? And have you seen this work in other sectors? And again, try and keep your answer as brief as possible.
Thank you. I do believe that youth, and not just youth-centered PHC systems, it's all about human-centered systems. How do we design programs that respond to the needs of not just the young population, but all cohorts? And I've seen this work. In Kenya, for example, and in Africa, we have movements of young people who are deeply involved in the design of benefits packages for UHC in their different countries. And what's really unique is that we do not just involve young people, but then the engagement of young people is tracked and measured, such that policymakers can say, as a result of engaging young people in these processes, our systems and policies have become much better because the youth gave input on their priorities, on their needs, because we understand what we need, we understand where the gaps are in the services. So it's not just about having youth engagements and human-centered approaches, it's about measuring and tracking and being able to show the outcome of involving young people. So I have seen this work, and it only works when it's measured and tracked. Thank you.
Thank you very much, and thank you for your question. We'll take a question from the central microphone.
Hi, I'm Fran Baum from the People's Health Movement and Flinders University in Australia. And I would like the panelists to respond to the fact that we're trying to implement UHC in a world that's growing increasingly unequal, where something like 40, I think Credit Suisse says 42 of the richest people in the world have the same wealth as about half the population, 3.5 billion, which is unbelievable, and we haven't really discussed that. So the question I'd like to think, and as Anders has said, we need taxation to achieve UHC because that will fund it. And yet we have so many corporations and people avoiding tax. So the question I'd like to ask is, do all the panelists agree that we need to ensure that no corporation or ultra-rich person is left behind in paying their tax to fund UHC and the other social determinants of health? Thank you.
Thank you. Who would like to take that question? Daniel, is that one for you maybe?
Anders is saying we can all agree on that. Taxes is the price we pay for civilization. And whereas a given society in a political economy may struggle to decide how much is right, clearly when you are less than 20% of the economy in taxes, you are not going to have a great civilization. On the other hand, if you go over 60%, you may end up destroying the economy. So what is that right point? Every society will negotiate that. And in the end, the earlier question of the students about value is about solidarity. So to the extent societies do that, we do well. And I'm happy to point out, if you haven't yet seen the art work by the children of Thailand out in the corridor, you will see when they paint about USC, it's about people and it's about solidarity. But yes, taxes has to be how you resource it.
Thank you. We'll take one very quick.
Very quick. I mean, the challenge is to change systems that is already unfair, where you have private funding for people that can afford and good quality and public for those who can't afford. So, I mean, I felt a bit embarrassed speaking about the system in Sweden because I know it's going to be very, very difficult for many other countries. We should strive there. I spoke to a colleague from South Africa here, what they're doing in South Africa right now. But it's difficult. It's going to be extremely difficult actually to change the financing. Big political decisions are needed, but it's going to be difficult.
Thank you. So one very quick final question over on that side.
Thanks. My name is Anna. I'm from the People's Health Movement in Europe, and I would just like to hear some reflections from the panel on the fact that for now we have only talked about financial protection and the financial aspects of the UHC. So while we can agree that economic analysis can be very valuable and useful in life, I think that we have also witnessed during the past that they have been quite, well, not useful. Actually, they have been harmful for people's health, and that we are not considering this evidence when talking and planning for UHC. So I would like to know, well, from the whole panel, but maybe more specifically from the World Bank, when are we going to take the evidence into consideration, and when are we going to focus more on the social and commercial determinants of health, which are very key into achieving primary health care and health for all? Thanks.
Daniel, one for you maybe.
Look, I mean, I think, I guess the point I wanted to come across is that we need convergence between the dialogue on universal health coverage from the health technical aspects and the conversation on universal health coverage from an economic aspect. And in my view, it's like the yin and the yang. They have to go hand in hand, and we cannot neglect either of them.
Great. So I think, unfortunately, I think we're going to have to end it there. I want to reflect. I think that we've covered an awful lot in the last two sessions. We've talked about the sort of financial pressures, the role of things like good taxes. We've talked about the political agenda. We've talked about the aspirations of young people, the challenges of an aging population, the academic success, the evidence behind how we're addressing UHC, and that sort of action, the call to action that we need from our leaders as well. I think PMAC is such a unique meeting. It's a sort of true community of people who want to try and achieve UHC. And I think this is hopefully just the start of the discussions we're going to have over the next 3 days. We've got a huge opportunity and I think a lot of responsibility as well to address some of these in the parallel sessions. So I know you had lots of questions today. Please bring those to the sessions over the next couple of days, have these discussions, and hopefully together we can accelerate progress towards UHC. I'm going to hand back to Mr. Hashimoto for some closing remarks, but first of all, please put your hands together to thank all of our panels today.
Thank you very much for joining the panel discussion today. Following the political momentum toward achieving UHC through the UN high-level meeting in last year, it was grateful to have fruitful discussion in this session. Japan will continue to share experiences of all the related countries and take steps toward achieving the Sustainable Development Goals. Japan also would like to keep working together with Thai government, all the people related with PMAC, and global health partners to promote UHC in the world. Thank you for your attendance. Thank you.